Okay, so now, no, we'll just go have two talks to complete. So what we are going to be talking now is neuro-ophthalmic visual fields. So now we know how to reliably evaluate a particular visual field. Let's see how to do it neurologically. Now, why important aspect of fields in neuro-ophthalmology? Because of the specific anatomy of the visual pathway allows topographic localization of visual fields. Ideal is Goldman kinetic, but what we tend to use is the automatic static perimetry. And as you know rightly, that basically the left part of the visual field stimulates the nasal retina and vice versa. From the retina arise the optic nerves which cross at the chiasma, forming the optic tracts, which carries the same-sided temporal fibers and the cross nasal fibers to the lateral geniculate nucleus, the optic radiations, and the primal visual cortex. And because of this particular the structure which is there, we are able to have classical visual fields. So from 1 to 8, if you notice, you have the classical visual fields, and we will decide how to evaluate that. Now, unlike what we've done in glaucoma, when you are evaluating neurological fields, always have both the fields in front of you. Especially for students, if they give you one field, ask for the other one, because you need to study them bilaterally. So right eye in your right side, left eye to your left. Note the blind spot. It should be temporally in both the cases. You have to look at the gray scale. Unlike glaucoma, where you look at the pattern deviation, here you look at the gray scale. And you ask these powerful questions. 6. Is the field loss? These 6 questions I'll take through, and every time you evaluate them, look at these 6 questions. Is the field loss unilateral or bilateral? Because if it's unilateral, it's anterior to the chiasma, and if bilateral, it goes behind. Like for example, note here, if you're looking at these fields, which is anterior, you will only find one eye involvement. And if you go beyond the chiasma or at it, as you can see here, you will find bilateral visual fields. So look at both the fields. The next question is, does the defect respect the vertical meridian? Because if it does, it's chiasmal or posterior chiasmal. Now look at all these lesions which you can see from 3 to 8, they are respecting the vertical meridian. And therefore, if you have something like this, as I said, look at both the fields, you know where to look at. Then, and you see anteriorly, you will see only the one eye being involved. Now, then the next question is, what is the pattern? It could be a central scotoma, it could be centrocecal, which involves the blind spot, a paracentral, it could be altitudinal, which we just saw respects the horizontal meridian, it could be even arcuate in neuro-ophthalmology, or hemianopia, where it involves either to the right or the left or the point of fixation, but respects the vertical meridian. It does not cross that. Quadrant anopia is basically involved between your vertical and the horizontal meridians. So once you know the pattern, you need to look whether the defect is bilateral or not. If it is bilateral, then is it homonymous? Now what do you mean by homonymous? This is a temporal field of one eye and the nasal field of the other eye. Because if that is present, we are looking at posterior chiasmal lesions. And then comes, if it is so, which side it is, because it's always to the opposite side of the field defect. Now look at these lesions where you can see these are homonymous lesions, which are all, if you notice, with lesions from 4 to 8. And if you notice, these are left-sided, so obviously the defect is going to be right optic tract or radiations. Then look at this field. This is the left homonymous which you are getting. You will have a defect in the number 4, which is basically incongruous, will have RAPD and optic atrophy, which are classical features of a lesion like this. This is the optic tract. Now if you have something like this, which is called as pie in the sky, we are looking at a lesion number 5, which is the temporal lobe. And if you have something like that, this is pie in the floor, we are looking at a lesion in the parietal lobe. So again, if you are looking specifically at lesions in the parietal lobe, you look for parietal lobe signs, and temporal lobe, the temporal lobe signs. So this is what will tell you pie in the sky and pie in the floor. Then coming to now, what is heteronymous? Now we saw homonymous. Heteronymous means these all had one-sided. You are always seeing same side. But look at here, this is not same side. These are same field, meaning both fields. And that is called bitemporal hemianopia. And when do you get it? Only and only when the chiasma is involved, because here the nasal fibers cross, hence the temporal fields are getting involved. So when you have a bitemporal, there is no other differential but a bitemporal hemianopia due to a chiasmal tumor. So remember that if you forget the fields like this, you know where to look at. So once you know the side and the bilaterality, you should find out if the defect is congruous. Now what do you mean by congruous defect? It is, first we'll tell you that it occurs for most posterior lesions. We are ideally looking at an occipital lobe lesion. See, look at this defect. It does not exactly resemble the other eye in terms of shape, extent, and laterality. That's incongruous. Then when you are looking at something like this is perfectly congruous. And this would indicate an occipital lobe problem. So now once we know that, let's look at this cases, a few of them, to detect how to evaluate. 6 important questions: if the field loss unilateral or bilateral, the pattern, does it respect the vertical meridian, if it's bilateral, if it's homonymous, which size it is, and if the defect congruous. So if we have a patient like this, 6-6 vision, 6-9, can anybody tell me? This is only involving one eye, does not cross the meridian. It is a defect which is like an arcuate respecting the horizontal meridian. So where would we expect the problem to be? Anterior to the chiasma. So you have to look at the nerve. So go carefully. This patient has a pale nerve. This is a case of left eye anterior ischemic optic neuropathy. So this is how you detect. And okay, look at the other field. This is a patient who had basically 6-6 vision in the right eye. Everything was normal. Color vision was normal. But in May 2014, she came with a drop of vision. And if you look at the defect now it's showing a centrocecal scotoma, if you can see. So again, you know something, we need to go back and check. We realize there's something involving the blind spot. She actually was case of Taka-Yasu. This is an anterior ischemic optic neuropathy detected by an RAPD, underwent the IOTO ICA bypass, and the field resolved. So basically, looking at the RAPD for the optic nerve involvement and the field test, we could diagnose the problem. Now let's look at this. What do you think this defect is? Again, when you have a defect like this, what should be your next question? I want the other eye field. Don't evaluate any patient unless you get the other eye field. Now look at the other eye field. Yes, there is a field. So we come to our questions. This is basically central defects, but it's bilateral, it's homonymous. So we are looking at a lesion beyond the chiasma, the same questions. So if you're looking at beyond the chiasma, it's a superior, inferior, right paracentral hemianopic scotoma. When you're looking at a congruous lesion, we're looking at an occipital lobe. Let's understand the occipital lobe representation. There's a calcarine fissure, superior and inferior, and the tip of the occipital lobe. Now, tip of the occipital lobe is known to go and select the central defects. So what we are looking at is at the tip of the occipital lobe. And how did we reach the diagnosis? Only by looking at the two fields, knowing it's bilateral and bilaterally homonymous. So what this patient actually had was a tumor in that. So it's the field test, just looking at the two fields gave us the diagnosis, which is a meningeo of the left occipital lobe. Let's look at another patient, 62-year-old female complaining of visual loss. On hysteria, had undergone multiple because she kept seeing visual loss and they felt nothing was really wrong with her. She was even on glaucoma treatment. But if you look carefully, the disc looked more or less okay. But when we did the visual field, we saw only one eye visual field is there. It is respecting the vertical meridian. But how is the other field normal? So is she actually having an issue? Is she hysterical blindness or organic? No, note carefully. It is respecting the vertical meridian. And if you go closely, you will see there is some sort of an optic atrophy. Now let's look at our description here. When we have something just pre-chiasmatic, which you have something like this, you would have missed actually the peripheral scotoma which occurs in this patient. And hence, we need to look at the chiasma more carefully. This patient actually had a pituitary tumor which was causing it. And this classical field is called as monocular hemianopia of trachea. So instead of treating her as a psychological case, all we need to have to understand the visual fields and get an MRI done. So we were able to salvage her life by getting the surgery done. Lastly, this case, now I guess everybody has quite understood. 52-year-old, 6'6", 6'12", temporal pallor. What is this defect? Yes, this is a bitemporal hemianopia, heteronymous, nothing else, but this patient had a pituitary adenoma. And to just tell you that nowadays in a patient, especially for children who come with craniopharyngioma, may have defects like this, we are not able to do the visual fields, and OCT comes to our rescue. OCT of a macular ganglion cell complex shows binasal thinning, which is very classically corresponding to the temporal field defect. So in cases we are not able to do, you should be able to do this to pick up the problem. So like for example, a patient who has a pituitary adenoma, if you do the OCT, if it's normal, like you see it's normal, and here also if you see the visual field defects can detect or not, yes, if you find these nasal defects, that means you know there is a temporal, there is a nasal compression. You should refer him to the neurologist, correlate it with the tumors. If there is a problem which is compressing, you can go ahead and get the surgery done. And this nasal GCC thinning is helped. But in a patient like this, where there is overall RNFL thinning, which is significant, and there is a significant loss of the entire macular GCC, we know this is a long-standing compression. You need to go ahead with surgery to at least salvage whatever it is. But in the initial case you saw, if you would have salvaged that and operated earlier, the pituitary adenoma, you can get back the visual fields completely. They reverse. But in a situation like this, will not reverse completely. So it's always good to detect, do the visual fields, and correlate with your GCC. Thank you. And I will just take the next talk on optic atrophy, how to evaluate.
mix of cases where you have optic atrophy and look at the various causes. When you see a temporal pallor, how do you evaluate whether it is neurological or glaucoma is something that we would describe with some cases. Yeah, it's showing, Jyoti. Yeah.
So it's very convenient that you have actual glaucoma and you have disc elevation and all that. It's easy to diagnose. But what happens is if you have a pale disc, what do you do next? What do you think it could have happened? What would happen future? What do you investigate is what the subsequent presentation I'm going to talk to you will help you through.